Apeksha sir, and our JDN Chairman, Dr. Hariharan sir, for the constant support and motivation rendered. And I wish the session a very great success. All the very best. Thank you.
Thank you. Thank you so much, ma'am.
Thank you, ma'am.
I would request Dr. V.S. Hariharan sir, who is the State Chairman, IMA JDN to grace this occasion, sir. Over to you, sir.
Good evening. Thank you, Yamuna, for all the effort, getting in almost 350 to 400 people for the first session on pediatrics. I think it's great going. And let me not stand behind between the learning and this. I think we'll have a great start with Apeksha and other. Thank you so much for the opportunity.
Thank you so much, sir. I would request Dr. Apeksha Anand ma'am to take over this session. Over to you, ma'am.
Thank you so much, and which is very short notice. I'm very happy with so many participants. Thank you, sir, for giving me this opportunity. So let's not waste any time and we'll start. So first thing I want to tell you is congratulations on happily and successfully finishing your theory exams. But final year is more of practical. So a little small hurdle is yet to be there. So one thing I want you to tell that before exams, please get good sleep and then rest. Last moment reading is not going to help us much, but I want to make sure this session is very short and just which will cater to your exams. So if there are any second and third year students joining, this discussion will be very quick, brief, and mainly for the final years. So we will have another detailed class on CP, which will probably be 2 or 3 sessions, because each session will only go on for 1.5 hours. So today we'll have a 30-minute discussion starting from Sona. She'll start presenting the case. So at the end of the presentation, I can take some doubts, and I have a 10-slide PPT ready for you all. The last minute points, which you can revise just before going to exam. So we can start. Sona, you can share your screen.
Yes, ma'am.
Until she shares her screen, let me tell you, if you have taken CNS case, consider yourself passed in pediatrics. Okay, so go ahead, and if you get a chance, take it.
Once again, ma'am, sorry.
Yes.
Is my screen visible, ma'am?
Yes, you can start.
Good evening. So Master Ritvik, a 10-month-old boy coming from Tamilnadu, whose informant was his mother, whose history is reliable, came to the OPD with chief complaints of history of not attaining age-appropriate milestones. So since the complaint started from the postnatal period, I would like to start the history from the antenatal period. So in antenatal history, first trimester, this was a third-degree consanguineous marriage. Age of mother while conceiving this child was around 25 years. It was a spontaneous conception after 3 months of marriage. The conception was registered and immunized. There is no history of abortions or miscarriage. There is history of folic acid consumption throughout the pregnancy. There is no history of fever with rashes. no history of lymphadenopathy, no history of drug intake or radiation exposure, no history of blood transfusion, and no history of bleeding or spotting TB. Second trimester, quickening was felt at 20 weeks of gestation, no history of pedal edema, blurring of vision, seizures, no history of gestational diabetes mellitus. NT scan and anomaly scan were done and was said to be normal. In third trimester, no history of bleeding per vagina, no history of premature rupture of membrane, no history of decreased fetal movements, no history of foul-smelling liquor, and no history of burning micturition. Natal history, the baby was a term baby delivered at 39 weeks of gestation. It was delivered by normal vaginal delivery. The weight of the baby was 2.3 kgs, but there is history of prolonged labor. The second stage lasted for more than 1.5 hours, and then the baby was delivered using forceps. The baby didn't cry immediately after birth, so resuscitation in means of bag and mask ventilation was done. The baby was admitted to NICU and stayed there for 1 week. Postnatal history, there is history of neonatal seizures at 10 hours of life. The neonate was administered anti-epileptic drugs, and there is no history of difficulty in sucking, no history of neonatal jaundice, no history of cyanosis, no history of respiratory distress. The baby was handed over to the mother after 24 hours. The child was discharged on day 10. After discharge from the NICU, the child was apparently normal for 3 months, was feeding well, responding to sound. After which, the mother noticed that the child did not attain social smile and neck control by the end of 3 months. So I'd like to elaborate on
Okay,
development.
Sona, we'll stop here. Okay. Can you just go back to your previous slide?
Yes, ma'am.
Okay. So she has started from antenatal history. That is fine. So there are few things I want to ask you. Did the problem start from the postnatal period or natal period?
It started from the natal period, ma'am.
Right. Okay. So what do you think is the significant factor here, which was probably seen here during the natal history?
There is prolonged labor,
Okay.
and then the baby had seizures within 10 hours of birth.
Okay. So you have told me that the child was admitted in NICU for a week,
Yes, ma'am.
right? So there is no other detail available. Is the
Yes,
mother
ma'am.
aware or not aware of what is the problem?
The mother is aware, ma'am.
Okay. See. So when we are discussing about a child with CP and we know we are going to discuss about the cause of it, so you might have to elaborate a little more. So you can either say that in that 1 week what was done. Did the child receive oxygen, or did the child was on ventilator, or it received anything other than any IV antibiotics? Because what do you want to rule out with all those things?
Not sure.
Anybody else? You can either unmute yourself or you can message us.
Neonatal sepsis.
Very good. Neonatal sepsis. Then, yes, HI is already there in our history. So, yes, neonatal sepsis, meningitis, very nice. Neonatal encephalopathy, very good. There is one more thing which is significant here. Can you find out what it is? So, it's a forceps
Baby.
delivery, right? So, there is chances of neonatal hemorrhage, right? Right. So, and when we are having a forceps delivery, we cannot say normal vaginal delivery. So, you might have to tell an assisted vaginal delivery.
Yeah, okay, ma'am.
Right? Okay. So,
Yes.
she has pretty well summed up the antenatal, natal, and postnatal history. So, these are few small mistakes which you might encounter, and they might catch you where you have done the mistake. Okay. So, at this point, you should not panic because your history was very beautiful. So I want you to all read what are the causes in the first, second, third trimester, which will cause which will be the reason for CP. I hope you all know that, and I don't want to discuss and waste time on that. Okay, clear? We'll move ahead. Next.
So, developmental history. According to gross motor, ideally neck holding should have been achieved by 3 months, but the baby achieved it by the end of 5 months. rolling over should have been achieved by 5 months, but the baby achieved it by the end of 8 months. The baby still didn't sit in tripod position. The baby cannot sit without support, and the baby cannot stand without support, which should have been achieved by the end of 9 months. So the developmental quotient here is 55%, which indicates severe delay.
Okay.
Fine
Next.
motor development. Ideally, bidextrous grasp should have been achieved by 4 months, but the baby achieved it by the end of 6 months. Unidextrous reach and immature pencil grasp aren't achieved by the baby yet. The developmental quotient here is 44%.
Okay.
Language milestone. Cooing should have been achieved by 6 months, but this baby, the baby also achieved it by 6 months. The baby still cannot say monosyllables. The developmental quotient here is 66%. Social milestones. Ideally, social smile should have been achieved by the end of 2 months, but the baby achieved it by the end of 4 months. The baby should recognize mother by the end of 3 months, but the baby achieved it by 5 months. The baby still didn't develop stranger anxiety or cannot wave bye-bye. The developmental quotient here is 33%.
Okay, so which do you think all the domains are affected?
Yes, ma'am.
Okay. So one more thing, if you are telling about development, you can add 2 extra points: gross, vision, and hearing.
Yeah,
Okay. So grossly, so you're telling child is able to recognize the mother. So probably his gross vision is okay, and
Yes, ma'am.
able to turn to sound. So yes, grossly the hearing is okay. So you
Yes,
think
ma'am.
it's important for us?
Yes, ma'am.
Okay. Next.
So there is history of difficulty in changing diapers and putting trousers, history of difficulty in washing perineal region, there is history of difficulty in latching the baby on hip. The child interacts with mother, sleeps well throughout night without any disturbances. The child can follow lights and objects. There is no history of abnormal eye position, drooping of eyelids, no history of deviation of angle of mouth, facial asymmetry, loss of nasolabial fold. The child can respond to sound. There is no history of nasal regurgitation while feeding, and there is no pooling of secretions. The baby can move its neck from side to side, and there's no history of abnormal movements of tongue. The child is able to perceive sensation while bathing. Bowel and bladder control is not attained. There is no history of insensitivity to pain. There is no history of bed sores. There is no history of abnormal movements. There is no history of vomiting or feeding difficulties. No history of constipation or recurrent respiratory tract infections. Diet history, the child was... Yes,
Okay. So why is it necessary to ask so many negative history? Can you tell everybody why you have asked everything?
yes, ma'am. So I've tried to see the cranial nervous system, the whole here, ma'am. So child interaction with its mother and sleeps well throughout the night points out towards the higher mental function. From follows lights and objects, no abnormal eye position, deviation of angle of mouth, and there's no abnormal movement of tongue. All these points are towards the cranial nerve movement. Cranial nerve involvement, and the sensation while bathing like denotes the sensory involvement, and then bowel and bladder control denotes the autonomic nervous system.
So at the end of any CP, so at the end of history, we should be able to come to a diagnosis. So at the end of developmental history, will you be able to tell if the child is having what type of developmental delay?
Yes, ma'am.
Yes, very good. Okay, so next.
Diet history, the child was exclusively breastfed till 6 months and still breastfeeds. Complementary foods like boiled vegetables and idli are given. Immunization history, the child is immunized till date. And socioeconomic history, the child belongs to a lower middle class according to modified Kurzgesondte scale. Treatment history, the mother reached medical attention at 6 months of age and the child is undergoing physiotherapy currently.
So a few points in diet history. Can you go back?
Yes,
See, three things are very important in pediatrics. One is the development, one is the diet, and the immunization, because those three things make us different from general medicine, right? So mostly you will be asked specific questions in diet, immunization, and socioeconomic. So you might have to elaborate diet history a little more because child is 10 months, right?
yes, ma'am.
So you have to ask expected calories, expected proteins. So why am I asking? You think it's important to know its diet history?
Yes, ma'am. The child can develop protein energy.
Very good. So the child will have feeding issues, the child will have micro aspirations, and the child will also have failure to thrive, right? They might not be attaining age appropriate weight and height. So we want to find out what exactly they are. See, I'm not sure if everybody will ask it, but make sure at least you know in a brief, because when you are presenting, you'll be given sometimes half an hour. So, but make sure you know a little of it, the diet history by the recall method. Okay. And immunization history, we might have to add few other points. What was the last vaccine given, and what any optional vaccines have been given or not. So why do we ask for that?
Any adverse events following vaccination,
Yes.
and to see if the child has been vaccinated against, the child is following all those vaccination schedules.
Yes. So, and one more thing is, especially in CP children, they are very prone to recurrent respiratory infections. So, optional vaccines also become important, like our flu vaccine, and anyway, pneumococcal is given in government schedule. So, you should ask which is the last date of immunization. Okay.
Okay.
All right. So, treatment. So, treatment. The child you said had seizures. So, is the child on any medication for seizure?
Not currently, ma'am. The child had seizure only after birth, at the 10th hour of life. After that, child didn't develop any seizure, so the child is currently not on any
Yes.
epileptic
So we might
treatment.
have to put that point, because at the beginning you said that the child developed seizure on day 10 of life, right? So at here you might have to elaborate that postnatally the child developed seizure on day 10 of life, following which he was or not started on any medication, and the parents were told to discontinue whatever. That detail is important because we want to know what type of seizure it is.
Okay,
Okay.
ma'am.
Okay. So medicals was seeked at 6 months, and child is only undergoing physiotherapy. So was any imaging done or anything?
No, ma'am.
Okay. So that is also important. So because when at this point, when you are telling the treatment history, you should ask these leading questions to the mother. Have they done any scan to the head or not? Okay. Okay. So Sona will summarize the history for us.
Yes, ma'am.
Yes.
9 months old child, first born to a third-degree consanguineous couple with significant peripartum issues with neonatal seizures at 10 hours of life, delayed developmental milestones indicating global developmental delay and stiffness of limb for which the child has been receiving physiotherapy. So I'd like to think in terms of non-progressive motor disorder, probably cerebral palsy of spastic type.
Okay. So you have included there is one more thing, significant peripartum issue. So okay, fine, that's fine. So you can also tell that some significant birth history of birth asphyxia, right? History suggestive of
Okay.
birth asphyxia. So
Yes,
developmental delay, right? Okay. Next.
general examination, the child is alert, awake, quiet in mother's lap. Neurocutaneous markers are absent. Posture, upper limb, adducted at shoulder, flexed at elbow, slightly flexed wrist, flexion of fingers, and presence of cortical thumb, knee joint, plantar flexion at the ankle joint. Scissoring of lower limb is positive.
Okay.
Head to foot examination.
Okay, just can you
Microcephaly.
tell me if there are any positive points in head to foot?
Yes, ma'am. Head circumference was 36 centimeter, which indicates microcephaly, and there is presence of cortical thumb.
Okay. So what is cortical thumb?
Fisting of the hand, ma'am, with thumb inside and folding the finger.
Okay. So why have you highlighted that in specific?
That's very significant in cerebral palsy.
Okay. So what is that called? That symptom called?
Crickly sign.
Okay. So have you heard of the what is called as early markers of CP or soft markers of CP?
Yes, ma'am.
Okay. So can you tell us one or two?
Yes, ma'am. One is this cortical thumb.
Okay.
Then,
Anybody else who want? You can answer in the. Okay, we have somebody has told us scissoring. Okay, and then
this microcephaly.
okay, high pitched cry, very good. Seizures, very good. Clonus, commando crawl. Okay, what is commando crawl? Somebody has written good. Okay, clonus toe walking, very good. Early hand preference. Then incessant cry. Okay, so we have good answers, very good. So I'm asking this in particular because once your presentation is very good, so they'll start asking you the next level questions. So these will be the next level of questions because you have answered all the basics well. So the next set of questions will be all these things. So good. Next, we'll move.
So there's no pallor, no icterus, no cyanosis, no clubbing, no lymphadenopathy, no edema. The vitals, heart rate was 110 per minute. Regular in rhythm, no specific character, no radial delay, no radiofemoral delay, and all peripheral pulses were felt. Respiratory rate was 28 breaths per minute. Blood pressure was 80 by 60 millimeter of mercury, measured in right upper limb. Saturation at room temperature was 99%. Temperature 98.6 degree Fahrenheit, measured at the axilla. Anthropometry, weight of the child was 6.5 kg against an expected of 9 kg when plotted in World Health Organization weight for age growth chart fell below the third percentile, and length of the child was 66 centimeter against expected of 73 centimeter when plotted in World Health Organization height for age growth chart fell below third percentile, and the head circumference was 36 centimeter against an expected of 45 centimeters.
That was below what
Cranial
centile?
Ma'am?
Head circumference. So anthropometry. So what centile was head circumference? Less than third?
Below third. Below third.
Okay. So at this point, I want you to all revise before going to exam the anthropometry very thoroughly. So you should be able to tell what type of malnutrition, acute or chronic. Okay. Please see those tables and go before your exam. And head circumference, microcephaly, macrocephaly. You should know the centiles and you will be asked to plot in the charts. Okay. And this can come in your OSCE also, especially the anthropometry. Okay. Right. Next.
Cranial nervous system examination. Higher mental function. The child was awake, responds to call, and can recognize the mother. Cranial nerves. First nerve couldn't be checked. Second nerve, the child is able to recognize mother from one end of the room. Color vision, field of vision, and visual acuity couldn't be assessed. Third, fourth, and sixth nerve, eye movements are normal. Fifth nerve, conjunctival reflex and pain sensation were elicitable. Seventh nerve, no loss of forehead wrinkling, no difficulty in closing the eyes, no facial asymmetry while crying. Eighth nerve, the child is able to respond to sounds. Ninth nerve, regurgitation of feeds are absent, uvula is in the center, and gag reflex is present. 11th nerve, the child is able to move his head from side to side. 12th nerve, there is no fasciculation of tongue or wasting of tongue muscle.
Okay. So since your child is small, 10-month-old, so there are a lot of things which you cannot examine. But if it's a bigger child, like 5 years or 6 years, they will expect you to do a few exam points, and you should be able to know what is the origin, what are the nerve roots for all the cranial nerves, and you have to also carry your kit, and you should know where you're using what. So cranial nerves are something in examination which are very simple, but you tend to do mistakes. So please make sure you read the cranial nerves the day before examination, especially the location. So they will ask which nerve is where is it present. Okay. So please make sure you read that before you go to the exam. Next.
Spinomotor system. The bulk is equal in both upper and lower limbs. There is no muscle wasting.
Okay.
Tone was in.
Yeah. So bulk, that's all you want to write? Anything else you want to tell in bulk?
The measurement of the upper and lower limb.
So it's very important for us to measure. So where do you measure?
In upper limb, the mid part of the arm, where the bulk is maximum.
Okay.
And in in the arm, and then coming to forearm at the junction of upper 1/3 and lower 2/3. And then coming to the thigh, where there is maximum circumference. And then at the leg muscle, similar to forearm, upper 1/3 and lower 2/3, the calf circumference.
So there are measurements and landmarks which you have to study. So it's all given in the books. You can go through it. But if you have not done in the exam, you please tell, sir, I have not done. Okay. So, and if you don't know, please tell, I don't know. All right. So this is one point I want to highlight, that it's okay if you have not done something, but don't try to make up during the viva. Okay. So there is something called as the 2 points from where you measure. So please read that thoroughly and then go. But they will expect you to write the measurements. Next. Tone. Yeah.
Tone. Tone was increased in all 4 limbs, in both in right and left side, in upper and lower limb.
Okay.
The power, the best observed power was 3/5 in upper limb and lower limb on both right and left side.
Okay. So what are the, how do you check for the tone?
Tone, I passively flex the joint, ma'am.
Okay. So.
And then if I feel resistance during one motion,
Okay.
it's passive.
So
Hypertonic.
at this point, you should know about difference between spasticity and rigidity. So I want you all to read that before your exams. Don't want to discuss it because we are already running short of time. So make sure you know what is the difference between spasticity and rigidity. All right.
Yes.
So since this is a smaller child, power is fine. Best observed 3/5. So how do you write it in a bigger child? Where do you check the power? Where do you check the power? Yes, anybody else? Where do you check the power? Yes, very good. For each muscle, you're supposed to check. So all the joint, all the muscles, you have to specifically check. It will be joints, not the muscles. So it will be power at the joint. So you have to flex and give pressure, extend. So it will be starting from shoulder, here, legs, arms. So specifically each joint, right and left, you have to check the power. Okay. So make sure you power of the muscle has to be written and graded properly. Biceps, triceps, yes, everything has to be checked. Okay. So since this is a smaller child, best observed power is fine. Okay. Next one.
Deep tendon reflexes. In upper limb, biceps reflex was brisk on both right and left side. Triceps reflex was also brisk on both right and left side. Supinator reflex was also brisk on right and left side. Lower limb, knee reflex was exaggerated both on right and left limb. Ankle reflex was brisk. Superficial reflexes. Corneal, conjunctival, abdominal, and cremasteric reflex was present. Plantar reflex was of extensor, bilateral extensor type.
So the child is 10 months old. You think plantar extensor is normal or abnormal?
It is normal.
It's normal. But here, can we take it as normal?
In this case, it can be abnormal.
Yes, very good. So tell confidently, you know it. Okay? Right, next.
Primitive reflexes, Moro reflex was absent. Asymmetric tonic neck reflex was present. No abnormal startle reflex was present. Palmar grasp was present. Plantar grasp was present. Suckling is present. Pull to sit. Head lag was absent. Ventral suspension, the head lies above the plane of body, and vertical suspension, scissoring of limbs were present.
Okay. So what do you think if can you go back? If asymmetric tonic neck reflex is present, then what will not happen for the child? Rolling over, excellent. So it's very important for you to know at what age this reflex starts and what age these reflexes disappear. So primitive, it's called the primitive reflexes because they are present from the newborn period. Which is the non-primitive reflex? Anybody can tell me? Okay, this is like a gold medal question. That's something at undergraduate level, I don't think they're going to ask you, but then it's always very good. Lando, parachute, very nice. Okay, So all of you are aiming for a gold medal. I'm so happy. It's a very active batch. Right. Okay. Next, we'll move on.
Sensory system, the child was able to perceive pain and sensation. Autonomic system couldn't be assessed. And cerebral system, there is no nystagmus and other signs couldn't be assessed. No abnormal involuntary movements were present and no meningeal signs were present. Spine and cranium were examined and was normal.
Can we say the cranium is normal when the child has microcephaly?
No, no ma'am. No gross. It
Okay.
was a
See, just don't comment on things which you're contradicting. So that's where we get stuck, right? You sometimes try to cover everything in your history and then you just get stuck in unnecessary positions. So it can be like, okay, you just told the cranium looks normal, right? But
Yes.
they might end up asking you, you just told microcephaly, how can you tell the cranium is normal? And then at
Yes.
that point, you will get scared. Okay, so you did a very beautiful presentation. So I just want you to remember that don't get yourself caught doing small mistakes like this.
Okay. Ma'am.
Okay, then right. So at the end of history and examination, so we have to summarize. Okay.
A 10-month-old child with cortical thumb, weight for age and height for age below and head circumference below the third percentile, and plotted in World Health Organization root chart. Microcephaly, scissoring of limbs, spasticity of all four limbs with best observed power of 3/5, and persistence of asymmetric tonic reflex, palmar grasp, plantar grasp reflex is probably a case of spastic quadriparesis type of cerebral palsy.
Okay. So when you're summarizing, it's always good to summarize from the history and examination. So that will be the final summary. So why I'm telling you this is the first roll numbers will get a lot of time. So the ending people, for example, when I was giving my exam, the examiner only said, tell me the summary of your case. And they just took away my case sheet. So I want you to be prepared for anything at that moment. So can you club your history and examination and just give us a summary in like 10 sentences?
Yes, ma'am.
Okay.
10-month-old child. One second.
Okay. Anybody wants to summarize? You can type it. Should create. Okay, I'll take your questions after this one. Okay, so I have a lot of questions here. Okay.
Shall I, ma'am?
Yes, are you ready? Okay, Sona is ready. Anybody else can try? You want to type a summary, because summary is the most important part of your this one, because there will be 25 to 30 people appearing for an exam in a day. So at the end of the day, they won't have much time to elaborate so much history. So summary is where you have to be very crisp and clear. Okay, I'll help you with it. You can start.
So 10-month-old Master Ritvik, who's first born to a third-degree consanguineous couple with significant peripartum issues with neonatal seizures at 10 hours of life and delayed developmental milestones indicating global developmental delay and stiffness of limb with cortical thumb, weight for age and height for age below the third percentile when plotted in World Health Organization road chart, and microcephaly, scissoring of limbs, spasticity of all four limbs with best observed power of 3/5, and persistence of primitive reflexes is probably a case of spastic quadriparesis type of cerebral palsy.
Very good, excellent. So she has covered most of it. So most of the times the end roll numbers get to present only this. So the positive points you should always remember, and they will ask you to elicit these sides sometimes. Okay. So before we go forward, I would like to take these questions. Should cranial nerves be told after history? Yes, see, in history itself, when you are elaborating the history, see, it's not a specific pattern. It depends from examiner to examiner, college to college. So I know this crowd has from both MGR University and Deemed University and the other universities. So some examiners will want you to go with in the regular format, like you present the chief complaint, history of presenting illness, and then go to past and do that. Or like how we presented today, most of them will accept this. Okay, and some of them don't want the antenatal history first, and then they want the directly starting from the history of presenting illness and developmental history. So you never know what pattern they'll ask you to present, but be ready with anything. And cranial nerve history has to be added in your history taking. So in your history taking should have everything. It should have motor system for starting from higher mental function, cranial nerves, motor system examination, and also the complications associated, including the cerebral signs and any orthopedic complications. This is a small child, so we don't have any contractures, strictures, or anything. So that is one thing we have to be careful. Yes, okay. So we'll take few more questions before we finish. So summary is not equal to diagnosis. Yes, summary is not equal to diagnosis. So she has told the summary and then she has put it with the diagnosis. So diagnosis will be only spastic quadripartic type of cerebral palsy. So at the undergraduate level, more than this, they're not going to ask. Mostly, they're not going to ask you to localize the lesion. But if you know it's very well and good, they will ask you what is the localization. So it can be cortical, subcortical, or cerebellar. So there are different regions. I am not sure if you want to know all this in the nth moment and get worried about this. So at your level, I think a case of spastic quadripartic type of cerebral palsy is enough. Okay, then anybody else? So how to calculate, how to say the diet history for a weaning child? Okay, so diet history for a weaning child, first from up to breastfeeding after 6 months, the mother will be having somewhere around 300 ml of 300 to 400 ml of breast milk. So you can calculate approximately that, and then you can add the you can ask the food items they're giving morning, afternoon, and night, and you can calculate with whatever they're giving. So normally they give apple, banana, rice, ganji. So you can ask the quantity and calculate. It is the same like how you do it for the bigger children. Okay, then. So yeah, breast milk. Okay, so is it must to calculate yes, it is important. You will be asked developmental quotient. It is important. So if they are in a hurry, they might not ask you to present the whole developmental history. You might be just asked developmental quotient. Yes, functional classification of cerebral palsy. It's good if you know, but it's okay if you don't know, because CNS case per se is not kept in all centers for undergraduate level. So yes, it's good. So Sona, can you tell us the functional classification? She'll help.
Yes, ma'am.
Yes, tell me.
So there are 5 levels of functional classification.
Yes.
In level 1, it denotes the children. So the child can walk at home and schools and outdoor, and they can perform all those gross motor skills. But the main thing is the speed, balance, and coordination will be limited. In level 2, the child can walk, but they might need to use wheeled mobility while traveling long distances. And in level 3, the child may use a handheld mobility device while walking. And in level 4, the child need assistance of 1 or 2 people. And in level 5, they need a manual wheelchair, and their mobility is completely restricted.
Okay. So it's just enough if you know just grossly. It's whatever you know is enough. They will not go in detail. Mostly at the level of, it depends on the examiner. If you are excellent, so if they're asking you these questions, that means you're getting the top marks. Okay, so should we comment on past history? Yes. See, she is already past history, developmental history, everything becomes one in such cases with a long history. So you can just start with, she told no at 6 months there. So she can add the past history along with the history of presenting illness. Like they first seeked medical attention at 6 months of age. At that point, they told that child had some developmental delay. So following which was started on some physiotherapy. So now again, they have come at 10 months, right? So, okay. So I think I have covered most of the questions. So if anything else, I'll see later. So I have a small, okay. So we have any more? This one from Sona, any other things you have mentioned in your presentation?
Investigations.
Okay. Sure. Okay. So investigation management part, yes, you have to mention the other systemic examination, not in detail, But you should know why you're asking CVS and RS. So what do you want to know in respiratory system?
Child is prone for recurrent respiratory tract infection, so we have to rule out any.
Why are they prone for recurrent respiratory tract infection? Anybody in the audience? Yes, microaspirations. Excellent. Okay, so that's very important for you to ask those things. So these things they might ask you in specific. So okay, next.
Diagnosis.
Yes.
So this is probably a case of spastic quadriparesis type of cerebral palsy with microcephaly and global developmental delay of functional classification of grade 3, persistent primitive reflexes, probably due to hypoxic ischemic encephalopathy sequelae.
Yes, perfect. Okay, so this is the diagnosis. It's enough if you tell this much. So sometimes at this point, because she has presented very well, I will ask, can you localize the lesion or something like that? So at that point, if you are comfortable, you can answer, or else if like I am not sure, or if you know, you can tell. Do you know, Sona? Do you want to tell?
Maybe
Okay.
cortex.
It's okay. Well, cortical. Yeah, probably it's cortical, right? Okay. Then so investigations. So we will quickly brush. So what do you want to do in this child?
Urine screening test, CSF analysis,
Why do you
X-ray skull
want
and
urine
spine.
screening test? Is it important?
Yes, ma'am.
Why? So we have a history of significant birth asphyxia. So the child developed neonatal seizures, and then the child following which did not have milestone development. So how is the urine test going to help us?
To assess the kidney function.
Why do you want to assess the kidney function is what the examiner will ask. See, this is where you people do mistakes. So you have presented so beautifully. Don't comment on something at this point which you are not sure of. So, okay, some people have written inborn error of metabolism. Yes, they are third degree consanguineous marriage. You can substantiate telling it's a third degree consanguineous marriage. So, I would like to rule out any inborn errors of metabolism. Very good. Okay. CSF analysis, you think it is important at this point?
Yes, ma'am, to rule out meningitis.
Meningitis. So the child your child does not have fever. Your child does not have any other symptoms right now. So do you want to still do the CSF analysis? No? Yes, no?
Sure.
Yes, confident, not sure. Okay. So don't get yourself commented on these. So first prioritize what you want to do. First will be EEG, then neuroimaging, predominantly MRI. Okay. Because we have a strong natal event. So at this point, what you want to do is find out if it is an hypoxic event during the birth. And also you can check the vision and BERA. Okay. Then following which, so whenever you write, they are asking, mostly they won't ask. So tell these things first, then following which the other things. Okay. Okay. Next.
And the treatment will be multidisciplinary approach.
Imaging. Okay. Multidisciplinary approach. So I will, after this, I will try to share mine, and I have written a little for you. So can I share my screen?
And in the presentation.
Yes. So I have prepared a 10 slides for you. So this will be for your last minute revision. So I want you all to see these points before you go for the exam, because you tend to get confused or miss these points. All right. So I'll make it quick. So we have 10 more minutes and I'll finish, and I can take some more questions for whoever is interested to stay. So entire screen, right? Not able to share. Can be short and quick. So first you should know the definition of CP. It's a group of permanent disorders of movement and posture causing activity limitation. There'll be static encephalopathy. It's attributed to a non-progressive disturbance in the developing fetal brain. And motor disorders are accompanied by disturbance of sensation, perception, cognition, communication, behavior, and associated with seizures. Okay. So there are chances that they might ask you to define CP. So you should know the risk factors. So most common Risk factors antenatally will be a preterm child, any intrauterine infections, multiple gestations, any pregnancy complications. Perinatal will be birth asphyxia as in our child, and any complicated labor and delivery. This was the cause in our child. So postnatally, any other injuries, any trauma, any infection, and any other significant event leading to cardiopulmonary arrest. And the causes can be broadly classified into ischemic or hypoxic infections. Moving?
Yeah, it's moving, ma'am.
Okay. So classification, so broadly 4 types. It's enough for you to know this much. So spastic diplegia, which is the most common, spastic quadriplegia, hemiplegia, and extrapyramidal type. Okay. So based on the location in the brain, we will develop. It may be either cerebral cortex, cerebellum, basal ganglia, or if multiple areas are affected, we called it mixed type. Okay, so this is just for you to understand. So hemi, quadriparesis, and everything. Okay, so one more thing I wanted you to revise before you go is upper motor and lower motor neuron lesions. So upper motor neuron is from the brain to anterior horn cell, and the lower motor neuron is from the low anterior horn cell to the muscle. So the difference between the upper motor neuron lesion and lower motor neuron lesion, the site of lesion, this will be in cerebral hemisphere, cerebellum, brainstem, and spinal cord. Anterior horn cells will be lower motor neuron, nerve roots, peripheral nerves, and neuromuscular junction. So in UMN lesions, the muscle weakness will be quadriplegia, hemiplegia, diplegia, or paraplegia, and it will be mostly spastic or rigid. Okay, and there will be no fasciculations, and the child will have hyperreflexia, and there will be cortical sensations, and EMG may be normal. So lower motor neurons, predominantly the muscle tone is hypotonia, and there will be fasciculations. So the tendon reflexes either may be absent or low, and the abdominal reflexes are present here. And here the sensory loss, there will be peripheral sensory loss. So these are the early markers of cerebral palsy: persistent tone abnormalities, persistence of primitive reflexes beyond 6 months, early hand preference less than 1 year, cortical thumb or that will be constant fisting and adduction of the thumb. I have put a photo there. Lack of alertness, lack of social smile, stereotypical abnormal movements, falling of head circumference centiles, and persistent inconsolable cry. So these are the good prognostic markers: spastic diplegia, head control by 9 months, sitting by 2 years, and floor mobility by 2.5 years. And these are the poor prognostic markers: motor delay 6 months, not attained head control by 20 months, persistent primitive reflexes more than 2 years, not attained sitting or crawling by 2 years, inability to sit by 4 years, and inability to walk by 7 years. So I want you all to revise the primitive reflexes before you leave. I don't want to go in detail here. So just make sure you read what is the time it disappears, and when it disappears, what is the reflex, what is the milestone which you get. So early intervention and multidisciplinary approach, they might ask you at this point. So early recognition is important: occupational therapy, physiotherapy, nutrition is important, immunization, pharmacotherapy for seizures, gastroesophageal reflux, sleep, hyperactivity, and for a bigger child with severe spastic quadriplegia, so there'll be the spasticity will be relieved by using some medicines like botulinum toxin, and they will also do some orthopedic procedures. Okay, so I wanted to cover a few things which probably you would not have been like asked or studied till now. So these are some quick points. So please do remember these before the exam and just revise. Okay, anything else? I can take some questions, and if you want to ask any questions, yes, I will share the PPT which I have done, definitely. So I've just wanted to see if some students have the exam in the next 2 or 3 days. So don't read new things, don't panic. Okay, sleep, get at least 8 hours of good sleep, eat well, and go. All of you have studied your best, so the last day stress should not hamper your performance. And even if you don't do well, it's okay, it's just an exam, so you can definitely get over it. Okay, so don't feel bad if you don't present one case well. You have 2 cases, you have OSCE, OSPE, and many things in your exam. So, but try to be confident, be calm, and explain what you have seen and what you know, because in exams, I know sometimes in that hurry you might have missed examining some things. So if you have not done it, be very clear that I have not done this. Okay, so all the very best, and congrats Sona, you have done a very good job. I hope you get CP case and you will do well. Okay. Okay, so developmental quotient has to be calculated. Yes, so you the actual what is the attain at the age. So for example, the child is having this one at now 3 months, so the developmental age is 10. So the actual developmental age now and the actual age into 100, so that is developmental quotient. Okay, so I don't want to take much of your time. So those who want to like exit can go, and those who have some questions for me, I can take another few questions if you want. Okay. Right. Non-progressive and regressive global okay, so I don't think you have to know all this at this point. So if I tell the others who don't know, I don't want to panic them, because it's the end moment and I am not dealing in detail with the discussion of this point at this point. So let's skip the difficult part. A lot of questions. Sorry if I'm missing few. I mean, I'm not able to. What? Okay, so we can share you the slides. Don't worry. And I think there are few mistakes in her PPT also. So it's just be careful when you're presenting those. Head circumference is up to 5 years, yes. But in cerebral palsy, so you can get a bigger child, so head will be small. So you can say the head appears small for the age. Okay. God, my laptop is stuck. I'm sorry. Yes, for cerebral palsy, points in Aruchami, yes, all practical books are enough. So don't load yourself with a lot of information in the last moment, because you have very less time left. So just concentrate on the basics. So CNS will be only basics in pediatrics. They will not go anything beyond that for you. What I did only was a little higher level for an undergraduate, because I know most of you would have studied about the torch infections and whatever why it's quickening extra. All these things are very basics, which I'm sure at previous discussions and everything you would have done. And all the localization part, everything I will deal in detail when I'm taking a detailed cerebral palsy class with the 2nd and 3rd years. At this point, it will take a lot of time for me to explain, and it's already 10 o'clock. Yes, clonus and spasticity are different. Yes, see, so the clonus is what we see. It is because of spasticity, there is chances the child will have clonus. So yes, there are 2 different terms, and clonus you have to mention in the exam, ankle clonus. And you should know to elicit both ankle and knee clonus. Okay, I hope you all know the clinical examination. Cortical thumb sign name, it's called Critchley sign. Mid-arm circumference is for, yes, it's for 6 months to 5 years. Yes. So see here, mid-arm circumference here, what we are trying to see here is what I told her are the measurements for the bulk. Okay, so that whatever the age is, you have to take the measurements to see if there is any wasting. So yes, mid-arm circumference we have to write for all the other children. And I want, she has not written in detail what type the child has malnutrition, right? Weight is less, height is less, weight for height is less. So this child is probably acute on chronic malnutrition. So that thing has to be mentioned. Okay. Malnutrition is something again you tend to ask. Developmental quotient is for all domains: gross motor, fine motor, language, and social. Average of, I don't know. So they will not ask you average of it. They'll just ask you what is the DQ. of gross motor, fine motor, language, social. More than that, no. Standard nutritional value, yes, you have to know. Unfortunately, you have to by heart that if you cannot remember. Pediatrics is, you have to know the basics. Okay, so gist of summary. Okay, so for any case, I will tell you in detail. So first, you have to always in his history, you have to highlight the positive points, and summary will only have positive points. So you don't have to tell any negative points. So all the positive points from the history and the examination is a summary. Okay, so it's mostly the end roll numbers will only get to summarize. So start practicing to be fluently able to summarize the history. So it's almost 10. So we will wind up. So any other queries, you can mail me and I will probably share my email ID with you, and or you can ask our okay. So can we end the meeting? Thank you, Sona, with a very short notice. She has done a very excellent presentation.
Thank you,
And
ma'am. Thank you for
thank you,
coming.
everybody.
Thank
For
you so much,
giving,
ma'am, for an amazing session, ma'am.
we will meet tomorrow. Yeah, we'll meet tomorrow. Okay, since this is my first session, I don't know what were the positive, negative points. I want you to tell me so that tomorrow we will be able to highlight on those points. And I'm sorry I'm not able to take all the questions because there are a lot of them. So probably you can mail me in person, and I'll try to answer each one of you whenever I get time. I'll promise that. So what I don't know. I'm just getting missed with the questions here. So yeah, please, I'll share. Joel will share my details of my email ID. So you can all either mail me with your doubts. Yes. Thank you so much for coming in such huge numbers. So please tell me what extra you want, and if you want me to do something else other than what I did today, because this is mainly for the exam going batch. That is why I didn't go in detail each and everything. CNS case discussion will per se go on for 2 hours. I know, I mean, I'm sure your college people would have done it already. So I just wanted it to be very short and crisp for you to revise, because it's just last moment and 1 hour is a huge time. I don't want to take much of your time. Thank you so much.
Thank you so
So
much, ma'am.
can we, thank you. Yeah, thank you, Hari sir and Jamuna ma'am, for giving this chance. I'll meet you all tomorrow. Okay,
Yeah,
I want
thank
you
you so
all
much.
to study and come. It's nephrotic syndrome. It's something easy. So yes, I want more participation. Thank you. Thank you, Arun.
Thank you so much, ma'am. So tomorrow we will be having pediatric session on nephrotic syndrome case discussion at same timing at 9 p.m. Thank you so much for everyone's participation. Thank you, guys.